Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
Well, good morning, everybody, and welcome to Family Medicine Grand Rounds 2021. This is our first rounds presentation of the new year. I will introduce our first speaker today, and that is our visiting scholar, Dr. Yoram Singer. Dr. Yoram Singer, or Dr. Yoram, as his patients call him, is a specialist in family medicine and palliative care. He's been practicing medicine for about 38 years and began practicing palliative care in 1993. He works in a family practice, and he's director of a large home hospice program and works in a hospital-based palliative care consultation unit. He's been part of the Department of Family Medicine's faculty for about 32 years, teaching graduate and undergraduate students family medicine and palliative care. He has come to Ottawa in order to learn from us and to share with us his knowledge and clinical skills that he's acquired over so many years. So to hear more about teaching palliative care to family medicine, I present Dr. Yoram Singer.
Good morning, everybody. My name is Yoram, and I'm a family doctor. I've come from Israel on a 6-month sabbatical to spend time teaching and doing research at your Department of Family Medicine. It's a real privilege to be here with you. And this morning I will tell you a little bit about how we teach palliative care at our Department of Family Medicine at the Gurion University in Sheva in Israel. So in order for you to understand it a little bit better, I'll explain to you a little bit how the health system works in Israel, and from there you can see how we've developed the way we teach palliative care. So the Israeli healthcare system is a little bit similar to Canada in the sense that there's free healthcare for every citizen of Israel. The healthcare is defined in what we call the basket of services, which is defined by the Ministry of Health in terms of what healthcare services are available, consultations, clinics, lab tests, medications, investigations. It's all defined very, very specifically by the Ministry of Health. And for the past almost 7 years, palliative care has been finally included in the basket of services. Now, the healthcare service itself is administered through one of 4 health maintenance organizations, HMO, and everyone is entitled to choose to which HMO he or she belongs. They register with the HMO and then they get their services from the HMO being obliged to give the basket of services. So now if the HMO cannot give a certain service, for example, MRI imaging, then they're obliged to buy those services from one of a number of private companies which exist throughout the country. And it could be that in some places the HMO is able to give what we call in-house services, and in other places it cannot give in-house services, so they have to purchase those services from one of a number of private companies. Now, palliative care in most places, in most HMOs, is not given as an in-house service, and the services are purchased from one of a number of private companies that offer palliative care services. Now, the doctors, nurses, lab technicians, whoever it is, get paid by salary from the HMO. There is no fee for service remuneration for any of the services given in-house by one of the HMOs. The Department of Family Medicine is affiliated to the Ben Gurion University in Be'er Sheva. The administrative staff of the department, secretaries, and so on, are paid by salary from the university. But the teachers, especially doctors, but also nurses and social workers who teach for the department, are actually not given a salary by the university. We get grants, we get we are entitled to study grants, we are entitled to other grants, but we do not get a salary. So actually all the teachers work for one of the HMOs. That's where we get our salary, and teaching is done in addition to the clinical work. Now we'll talk a little bit about what the family medicine residency program is about. In our country, family medicine residents have a 4-year training program. The program itself is defined by a national Israeli scientific council, which defines exactly what the curriculum is, and it is more or less the same throughout the country, irrelevant of what university is hosting the residency program. The first year and a quarter are a block of what's called Clinics Part 1, where the resident is affiliated to one of the ambulatory clinics within one of the HMOs, and is tutored by a teacher, family medicine specialist, who has an academic recognition as a teacher for family medicine, and he shares the practice with the resident. So it's a one-on-one experience for 1.25 years. Every week there's an academic day, which is an 8-hour lecture and workshop experience, except for the summer. So they have 4 years of once a week academic day. They're irrelevant of which rotation they are taking part in. After 1.25 years, they have 1.75 years as a hospital rotation, including internal medicine, including pediatrics, including psychiatry, and 2 elective periods, which they can choose whichever they want. And the last year is called Clinics Part B, where the resident has a practice of his own and is mentored and tutored by a specialist who has academic recognition, usually within a same clinic, but not always. After 2 years in the program, they have a multiple choice exam. It's called exam part 1. And at the end of the program, they have an oral exam. It's a 4-hour exam. And only after they pass these 2 exams do they get their specialist degree. In Beersheba, we have decided to include compulsory training in palliative care. So as I said, this palliative care program that I will be describing to you exists A, only in Beersheba, and B, only for those residents who are employed by Clalit Health Services, which is the main HMO operating in the area. So we have about 14 to 16 new residents every year, and the other HMOs in Beersheba will have another 3 or 4 residents. Those 3 or 4 residents do not have the privilege of being able to take part in this training program. So like I said, this training program exists only. Here you see what the palliative care system looks like. It's a unique collaboration, in Israel at least, between the Department of Family Medicine within the Division of Community Health at the university and the HMO Clalit Health Services. You see that the service part is done by Clalit Health Services. We have a hospital consultation unit because the university hospital is owned and run by Clalit Health Services HMO. And we have a home care unit also run by Clalit Health Services, but not throughout the area. We have a main palliative care unit in Beersheba. There are sister units in Kiryat Gat, which is about 40 kilometers north of Beersheba, Rahat, which is a Bedouin township, about 20 kilometers north of Beersheba. I haven't added, but lately we've opened a new unit in Ashkelon, which is about 60 kilometers west of Beersheba, actually not far from the Gaza Strip, which is a challenge within itself. And we have a mobile Bedouin palliative care unit, which is run together and funded both by the university and by the HMO. The university is in charge of education and the resident program. We have a research unit, and we have something called Magan Center, which is a cancer wellness center, also run by the university. So, like I said, only family medicine residents working with the Clalit Health Services are affiliated to this program. And as I said, this program is run for 1.25 years during what's called Clinic Part A rotation, where the resident is affiliated to a certain clinic and does his rotation and his work at the clinic together with his mentor and tutor. It's part of the training program, so the resident will not get extra pay for working or for partaking in this program. During the first week of his clinic part A, he will meet with the program director, and the expectations and what his role will be is described to him, any questions. Then he will meet with the head nurse, and he will do a few home visits so that he will be able to see what the nurses doing this home care service are able to do, and what the connection between them and the resident will be. And he will meet with the program social worker, to look a little bit about psychosocial aspects of palliative care, and for him to be able to have a mentor in terms of the residents' challenges in dealing with treating people at the end of life. After this, or what's called orientation week, the resident will be allocated one patient who is being cared for by the palliative care unit, and he will be responsible for this patient, but not solely. In addition to the usual team, nurse, doctor, and social worker who care for this patient. So it's not instead of the doctor, but it's in addition to the regular senior doctor caring for this patient. He is expected to go for at least one home visit every week to examine a patient, to find out what the concerns and problems are. After or during, depending, the home visit, he will report both to the nurse and to the treating senior physician, and they will have a discussion whether there are any concerns, whether treatment should be changed, whether there are any new treatment options. Once a week, there is a team meeting, palliative care service team meeting, and the resident will then present his patient to the team, describing what's happened during the past week, any changes in medication, and any other concerns. In addition, the service offers a 24-hour service, so 2 nights a month, the resident will be on call. The on-call is at home by phone, and all the patients in the unit have this particular resident's phone number, and if there are any problems or concerns, they will call him as an on-call service, and either he will give a telephone consult, but if necessary, he will go and do a home visit. Either during the visit or after, he will report to the senior doctor, who is also on second call, so that he has a professional advice and tutor during the on-call. And honestly, this is the time when these residents learn the most. They have to face the problem themselves, come up with solutions themselves, and this is the most important learning experience. Once every 6 weeks, instead of taking part in a regular palliative care team meeting, we have a special workshop for the residents with one of the senior doctors and either a social worker or one of the nurses, in which we deal with concerns that the residents have about themselves in terms of dealing with loss, in terms of how it is to be a doctor, actually dealing with death, issues regarding communication skills, breaking bad news. What do you do if one of the children tells the doctor, don't tell dad what he has because if he knows, he'll commit suicide. All of these issues which come up very often during work in palliative care are assessed and dealt with in these meetings. This program has been running now for about 20 years. It's been changed over the years, modified, improved, but it's been running now for 20 years, which means that by now about 60% of specialists practicing in the field in family medicine have gone through this kind of a program, which means that a large number of family physicians in the community have a very good idea of what palliative care is about and what home hospice has to offer for their patients. In addition to this basic knowledge, we've shown that this rotation in palliative care trains family physicians in better communication skills, in better teamwork, and in generally commitment to patients and families. Some of these physicians have opted and decided to do a specialty program in palliative care and have actually become palliative care physicians. I did a study quite a number of years ago about the impact of this program. You can read it as a reference. And that's more or less what I had to say this morning. I'd be more than happy to answer any questions. Thank you.
Thank you so much, Dr. Singer, for that presentation. And I just wanted to invite folks in the department to consider what we're doing right now. Are there some things that we could work with Dr. Singer on if we wanted to do some changes or improvements or expansion of our current approach to palliative care teaching for our residents? So we have a great opportunity right now. Dr. Singer is with us, I believe, until the end of June. So please do think about that in terms of what the possibilities are in terms of program, and also Dr. Singer has also offered to support research questions and research activities. So,
good morning, Dr. Singer. May I go next?
Yeah, yes, please.
Okay,
Teresa.
Fantastic. That was an excellent presentation. I really like the overview of the program. At Bruyere, we usually have once a month continuing professional development for our team. And I would love it if you could dedicate a little extra time to our group so that we can kind of compare and contrast on what we offer our residents at Bruyere and get some insight from you in terms of how we could change that. So I'd be sure to have our admin assist to connect with you so that we can have you to ourselves for a whole hour.
Maybe I should mention something which is a bit challenging in this program, is that I don't know how it is here, but our residents come in slowly over the years. It's not that we have a program which begins, for example, on the 1st of September and ends after 4 years at the end of August. Every 1 or 2 months, we have another 1 or 2 residents who come in. So we have to work all the time, considering that some residents have more experience, some residents have less experience. Some residents are well into the program and have had maybe a talk about the alleviation of nausea and vomiting, and other residents have never heard about it. So that makes it a little bit more challenging. On the other hand, because it's more or less a one-on-one experience for the resident, it's easy to sort of fit that in somehow. But it is a challenge, makes it more difficult.
Hello,
Yeah.
Dr. Singer. Can I ask a question, Doug, or are we out of time?
Please do. No, we've got
Yes.
another time for another comment or
Thank
question.
you. Very interesting presentation, and you seem to have an extremely well-structured program and very in-depth with really quite a breadth of experience for the residents. I was wondering, what's the population basin that you serve? Because obviously there needs to be sort of the access to the necessary number of cases and for all those residents. So I'm just wondering about your total population basin that is served by your program.
We have the population of Sheva is about 750,000 people, and we serve about 620,000 population. At any one point in time, we have about 24 to 25 patients on the home care service. There are at the moment four doctors working on the unit, obviously not full-time, each one part-time. They are all family doctors. They all work in family practices as well. So it's there'll be about 24, 25 patients at any one given point in time at the service. We have about maybe 13, 14 residents at any one point in time. So it works well. I think one of the problems with having such programs elsewhere in Israel is that in the whole country, there are about 35 specialists in palliative care. So most family medicine resident programs don't have enough specialists in palliative care to be able to run such a program.
At this point, I'd like to introduce our next speakers. Dr. Rezaiefar. She's a family physician at the Briere Academic Family Health Team and assistant professor in the Department of Family Medicine. She's a clinical teacher, a former refugee, and above all, mother to two amazing girls. Dr. Rezaifar's interests are in medical education with a focus on simulation and technology to teach and evaluate competence in ambulatory women's health procedures, humanity, and advocacy. Dr. Yara Abou-Hamde is a second-year resident at the Department of Family Medicine here at University of Ottawa, and she currently serves as chief resident at the Briere academic site and has interests in mental health, global health, among others. And Dr. Farah Naz is a second-year family medicine resident as well at the Primrose Family Medicine Center. And she's an international medical graduate, and she particularly is interested in global medicine, palliative care, and narrative medicine. They're going to be speaking today about perspectives of unrepresented women in family medicine training.
Bonjour tout le monde et merci Maddie. Tout d'abord, on aimerait commencer par reconnaître que la terre sur laquelle nous nous rassemblons aujourd'hui est le territoire traditionnel et nocédé de la nation algonquine. Ensuite, j'aimerais remercier mes collaboratrices, Dr. Yara Abou-Hamde et Dr. Farah Naz, résidentes en médecine familiale. Finalement, j'aimerais remercier Dr. Christiane Rangel, medical sociologist with the Department of Innovation in Medical Education, who's the senior scientist overseeing this project, and Ms. Lindsay Cowley, the research assistant. The only conflict I need to declare is my being the mother of two girls and my interest in women's health, whether it be as my patients or as my medical trainees, given my identity as a female clinician teacher in family medicine. The rest of our team has no conflict of interest to declare. So why this work? Gender gap in medicine is closing, and admission rate of minorities are on all-time high. Yet equal participation of female and minority physicians remain low in workforce, academic medicine, and leadership positions. We're not unique in medicine. Last Saturday, Globe and Mail reported the most comprehensive Canadian data collected on salary records from 82 universities amongst all other publicly owned corporations and institutions. And they combined that with gender statistics to confirm that we were not alone. And of the handful of women who made it, almost all were white. Furthermore, we see headlines as such on the front page of our medical journals, indicating that systemic discrimination holds women and those from underrepresented groups back from reaching their full potential. So it is our social accountability mandate that requires effective integration of women and underrepresented groups to better serve an increasingly diverse Canadian population. And in order to do so, we need to go beyond the gender and now the color, as Globe and Mail put it. We need to look at the intersection of gender with other social determinants of health, such as age, ethnicity, sexuality, different abilities, social and economic status. Because when you combine these determinants of health with gender, that's when we hold women back. As a primary care physician whose entire career is built on understanding interplay of genetics and environment leading to one's behavior and health outcome, I needed to better understand what happens to these ambitious women entering medical school with dreams and hopes as they go through their training journey. So first, we needed to investigate the perceived challenges and opportunities that are experienced by these family medicine residents who self-identified as belonging to an underrepresented group. And second, we wanted to explore how such experiences impact their professional identity formation, relationships with patient, and career choices. This is a qualitative study, and our method examines intersectional analytical framework to identify major thematic nodes of data collected from semi-structured focus groups. And both Bruyere Research Institute and University of Ottawa's Ethics and Integrity Office approved this project. So who are our participants? As I mentioned, there are self-identified female with belonging to, but not limited to, one of these factors: gender identity, sexuality, sexual orientation, race and ethnicity, religion, age, physical abilities or different abilities, physical build, and social and economic status. And we define professional identity based on what Colette defined in 2018. And I quote, "Through student socialization within the profession, one learns to act in harmony with the practices of a particular community or group by internalizing its values and norms." So let's get to know our learners. University of Ottawa Department of Family Medicine is the largest department in Faculty of Medicine, training nearly 160 residents per year. 60% identify as female, 80% are at the English site, and 20% at the French site. 15% international medical graduates, and we don't distinguish between Canadians studied abroad and those who have immigrated to Canada. The second most common language spoken is French at nearly 40%, and the third most common languages are Arabic and Mandarin. We don't collect any data on race, ethnicity, sexual identity, sexual orientation, different abilities, or socioeconomic status. Now that we've known our residents, let's get to know the environment, Faculty of Medicine, in which they're getting trained. Why this is important is because history does matter, as the traditions, values, and beliefs held by previous generations hold an indelible impact on how we view our place in our communities and in the world. This is where our trainees learn to act in harmony and internalize values and norms. This is University of Ottawa First Class, 1946. and increase access to medical education for Franco-Ontarians and increase access to Catholic-friendly medical education were the foundations of this Faculty of Medicine. So what about the population our residents serve? Ottawa is a very rich city. The median family income in Ottawa, Gatineau, was $73,000 in 2004, highest among Canada's 6 largest cities, thanks to stable IT and federal government as top employers. The language, 50% English, 30% French, and 20% other languages. In terms of race and ethnicity, 23% are considering themselves as non-white, non-European, followed by about 6% top minority group, Black Canadians, followed by Chinese Canadians, South Asian Canadians, Arab Canadians, and finally our Indigenous peoples as the smallest minority group in Ottawa. And of course, the census, just like us, does not collect data on gender identity and sexual orientation, except we start in 2021 to collect these data. So what were our results? We sent email to all our residents, male and female, and we ended up with 10 participants. And please consider that we were in the middle of COVID-19, and navel gazing with us was not the top priority of many of our residents. We held 3 60-minute focus group using GoToMeeting, and sessions were recorded, anonymized, and transcribed by Dr. Abou-Hamde and Dr. Naz. So in terms of our descriptive statistics on demographic, we're very limited because we want to protect the identity of our participants. What we can tell you is that we had a wide range of Canadian universities, American, European, and North African experience. And in terms of diversity of identity, we had a nice representation on race, ethnicity, religion, sexual orientation, social class, and geographic and citizenship status. In terms of our qualitative data analysis, the data is very rich. And to be very honest, when I finished the first round of reading the data, I was inspired and wrote this little poem. And the sun kept on rising, as sure as a mother's love, as faithful as pilgrims, oblivious to their suffering. So far, we've had about 3 2-hour data analysis. And again, I can't thank Dr. Rangel's medical sociology's expertise enough, as the 3 of us stand on this bridge, looking at our reflection in the water and wondering how deep this water is. Scientifically, we're nowhere to be finished, but we certainly have one theme that we're going to be presenting. It's the most statistically significant theme that emerged from all 10 participants' narratives. And the rest, of course, you're going to have to wait for Yoram and Farah's FMRSP report. This one is called Intersection of Professional Identity Formation and Emotional Labor. All 10 participants experience otherness, leading to feelings of exclusion and isolation. All 10 were quite aware of the necessity of advocacy on behalf of underrepresented groups in medicine and in the society. And managing conflict between authenticity and valued norms preoccupied them, like an internal dialogue that they held in their head all day long when they were with their patients, as well as when they were with faculty and their colleagues. So conclusions so far, they face unique challenges based on our current cultural expectation and limited system levels. And these had unintended impact on their career choice, delivery of care to patients, and professional leadership possibilities. Of course, we would like to have our data tested provincially or nationally, but we don't have money. So we are inviting anyone with money to join our team. Why? Because it's not enough to tell little girls that they can be anything they want when they grow up. Unless we acknowledge that there will always be people who make them feel that they can't, and unless we find solutions to change systems which make them believe that they can't. Thank you very much.
Doug, I'll jump in. Boy, it's Claire here, and this is fantastic work. I'm so excited to see and read and hear about the next level of results. As chair of the department, what I can say, Parisa, is that fully supportive of trying to look for ways to change and I think address what you're raising. Two things that are already happening, I think that will be really relevant is the whole development of the mentorship program. So I think it'll be really important to get you involved in that and make sure that we create the right structure that's going to maybe help with this. The second thing is looking at the whole self-identification and whether or not in our selection process we can start to implement that. And on the Indigenous stream, I already have a proposal that was presented to me to try to, I think, embed that into our selection process. So that's under discussion. So I'm extremely, and the department is extremely open to further exploring this and leading to action. And then the second thing too, as I said, I'm sure we can, let's talk about the provincial national level study and how we can resource it. I personally will commit some funding from my own discretionary account to support this work. So I'm overwhelmed. I think this is fantastic work that you've done. Thank you so much.
Thank you, Claire. And on the issue of mentorship, actually, we have a very rich discussion on our result, because that was actually quite tremendous in terms of both the need for mentorship, but also this internalized value of the residents wanting to be mentors. And I'm very excited about the mentorship program we've created. So we'd be more than happy to share these data in terms of how best we can create that to both meet their needs, but also not overwhelm the few faculty that we have, because that was very interesting, the way they wanted to cross boundary. You know, it doesn't have to be you don't have to be a Black faculty to mentor a Black resident. And that was very prominent in terms of how the fact that you are underrepresented, how you develop that innate understanding of otherness, and therefore you're open to other underrepresented groups. So we'll definitely have lots of conversation around that. We only had 10 minutes to discuss.
Thank you, Parisa. Claire Kendall has a question.
Hi, Parisa and team. Thank you for the great work. I was going to say, just so you know, CIHR has prioritized intersectionality. They've identified it as a priority for them, intersectional analyses. So I think, you know, putting together a focused project that would be appealing to them would be a great opportunity. It didn't help us get our intersectionality project funded, but just so you know that they have specifically highlighted intersectionality as a priority for them.
Doug, it's Bill. Can I ask a question?
Please do, Bill.
Lovely to see this, Parisa. Clearly a very important topic, but I want to ask you something about the research methods. I don't know much about methods in this area, but I've heard somewhere once upon a time that you actually, by having 3 focus groups, you actually have 3 data points, not 10. And when you talk about something being statistically significant, I wonder if that's appropriate in the context of what appears more like a qualitative approach. So do you know anything about that you can shed some light on it for me?
Yeah, absolutely. So you're absolutely right. So when it comes to, so the way we kind of looked at the data, there's absolutely no way we could get p-value anywhere. Our numbers are so small, and correlating even the dynamic of each focus group, you're absolutely right, because each focus group ended up having its own dynamic a little bit. And so even correlating the dynamic of each focus group with the themes that were created was impossible. So what I was trying to portray for you is that there was a one theme that was presented regardless of what was the theme or the dynamic of the focus group was extremely prominent. And that was this whole concept of emotional labor, regardless of what the topic that was discussed. But you're absolutely right. We can't really use the same quantitative methodology in qualitative studies. And certainly Dr. Rangel has been an asset in terms of combing through the data. And as I said, we've only had 2 hours and data analysis, and we're nowhere to be completed. But you're right, we can't necessarily use that, but certainly when all 10 participants express a theme that is so prominent in qualitative studies, certainly that was a theme that became so important for us to discuss. So maybe perhaps I shouldn't use that term lightly. Thank you for raising that, but certainly it was extremely significant. And Bill, it's the first time I'm doing a qualitative study. As you know, last year I was doing a fellowship, and because I wanted to learn about qualitative research, I picked up this topic, which lands itself so well on qualitative data. So I'm definitely a junior, and I welcome anybody's mentorship on how to write this up.
Doug, maybe I'll jump in, and Maddie, you can send it. The Canadian Family Physician has an amazing qualitative checklist, and it's a great way when it's a reviewer checklist for qualitative studies, but it'll really key you in on the methodology and how to be thinking about it. Because actually, you've done a great job with the methodology. I agree with Bill, you shouldn't use the quantitative and be looking for any numerical statistical significance. It's really what you're doing is looking for themes. And there's different ways that you can enhance, or not enhance, but ensure the trustworthiness of your themes. But do look, Maddie, maybe you can send that link. Really nice. It's really very straightforward, and it's the methods piece of what you should be presenting in terms of your qualitative data.
Can I share this? David Ponca wrote this, and I love that, David. Actually, I think, I can't remember where I've heard that. Diversity is being invited to the party. Inclusion is being asked to dance. Thank you, David, for sharing that.
Thank you, and I appreciated your declaring 2 daughters as a conflict of interest. I often say that when I'm around a table talking about maternal and child health as well.
Thank you very much for the presentation, Dr. Rezaiefar. I was just wondering if you could elaborate on one of the findings that you had about the conflict between authenticity and the norms, the normative values.
Sure. I may quote actually one of the participants. So they were talking about, as a female, sharing our stories are very important to us. If you're having a bad day, at the end of the day, you want to tell somebody. And this participant talked about how her very well-intentioned male supervisor, when they met for their half day, and she started talking about what rough, week she's had, he immediately, very well-intentioned, started suggesting that she sees wellness, that she might be depressed, and that there's a lot of mental health issue that might be rising. So her concern here was that, the norm is being, and I use her quote, the norm of medicine is to be stoic. And certainly Dr. Rangel, who's the sociologist, who every time we meet and he asks me, how are you doing? And I say, oh, I'm doing fine. He says, oh, you doctors are such liars, right? And that's because this culture of being the stoic and being really hard, and yep, we could do this, right? And it's a culture. And so this female resident, and again, it resonated with many other residents, that the authenticity, they had to hide this authenticity. One of them being the need to share, because she certainly wasn't depressed. She certainly was not coping. She just needed to air a little bit her laundry and feel better. So that's one of the examples of the authenticity. The other one was one of our participants who's a lesbian. She's married to a woman, and she has this internal dialogue all the time in terms of whether or not, when she is in a women's health setting, if the patient discovers that she's a lesbian, would she treat her the same way that patients treat male residents and refuse care? So when patients would ask her, for example, in your situation, what you would do, of course, the patient's presumption is that she's a heterosexual woman. And so she would have to hide her authenticity for the fear of being rejected by patients. So these are two classic examples that were raised. And the other one was, of course, one of our residents who's Black, yet she called herself, I'm quite white passing. And so she would, or the other one who was of mixed race of Chinese and white. So even though she identifies as Chinese, she's seen as white. And so both of them would hide their identity because when there would be really racist comments about, especially in the context of pandemic with with our Chinese Canadians, so they would hide their authenticity and their identity for safety, essentially.
Parisa,
yes,
thank you so much. We've actually gone over time, but you can see most people have stayed on. So I think that speaks to the importance of the work that you're doing. So we'd love to have you back to present at rounds when you have your final findings, for sure, to continue this discussion. I wish you all a good day, and thank you very much for participating in rounds today.